So just before we get started, I just want to acknowledge that I am on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and that this land continues to be home to diverse First Nations, Inuit, and Métis people. I invite the audience to also consider a land acknowledgement from wherever you might be joining us from. Our CPE audience is continuing to expand across the country and beyond. And thank you for joining us. So today's event, you can see lots of people from lots of different sectors joining. Today's event is focused on plan sponsors moving into pharmacy. What does the future look like? And we have Mike Sullivan joining us to kind of get the discussion going. And then we'll have Jonathan Nahn joining us for some discussant remarks afterwards. And then we'll open it up to the general Q&A via the chat box after those remarks. So Mike, thanks for getting your slides up. I'll just provide a quick introduction for you. So Mike Sullivan co-founded Cubic Health in 2003 and serves as the company's chief executive officer. Cubic provides plan analytics, predictive analytics, clinical solutions, machine learning as a service, and pharmacy services to self-insured health benefit plans, ranging in size from 1,000 to over 500,000 employee lives. Cubic works with single and multi-employer plans and trusts to optimize the health of both plan members and the underlying benefits plan itself. Cubic's unique capabilities in terms of integrating and making sense of underlying claims data and implementing customized evidence-based solutions is driven by its proprietary analytics infrastructure and team of clinical pharmacists, data engineers, data scientists, and software developers. Thrilled to have you here with us, Mike. I know you began your career as a community pharmacist and have previous experience working in both the pharmaceutical and benefits consulting industries. I'll let you take it away from here.
Thanks, Annalisa. I appreciate the introduction. Can you hear me okay? And the slides are all right on your end?
Yeah, perfect.
Okay, terrific. I'll just jump right into things. I appreciate the introduction and the invitation. Anybody who knows me knows that it's not going to be easy for me to keep my comments to 20 or 25 minutes, but I will absolutely attempt to do that here so we can have a fulsome discussion, and I look forward to hearing a little bit more on the Discovery Pharmacy as well in between. I also encourage the audience, any questions you've got, by all means, please fire away. When we get into the Q&A part, I'm happy to jump into it. I was asked to speak about the topic of what's happening with respect to pharmacies interacting with private payers, plan sponsors themselves, moving into pharmacy, and what does this all mean and what does the future look like? And so let me just jump in and we can take it from there. I recognize there's a diverse audience here, but just in terms of setting some context for the comments moving forward, I think it's just important to level set here for everybody. There's a lot of these terms get used in different ways by different people, and just so that we're all on the same page here, when I talk about private payers, I'm talking about basically anybody in the ecosystem who's facilitating the claim, a prescription drug claim in this case, being paid for by an entity that's other than say a government entity, a private payer, typically speaking, an employer-sponsored benefit plan or association plan, etc. That's different from a plan sponsor. The plan sponsor, in the language you use, we're really talking about the individual entity that's underwriting the cost of the program. And that's often an employer or a collection of employers or some sort of benefit trust. The plan sponsor is sort of the key entity here. The term PBM or pharmacy benefit manager is also sometimes a bit of a vague term. That typically refers to the intermediary that may be processing a claim on behalf of an insurance company or a plan sponsor. But they're the transaction processors and the gatekeepers. And then you've got the insurance carriers. And I think very often most people confuse private payers with insurance carriers. Insurance carriers are a really important stakeholder in the overall private payer universe, but insurance carriers are not necessarily the actual payer when we're talking about larger self-insured plans to get into in a second. But oftentimes the insurance companies sort of, I guess, especially in pharmacy circles, is misunderstood to be the actual private payer or the plan sponsor, which is not always the case. The other big important sort of differentiation is the idea that there are fully insured health benefit plans out there. So if you're a small or medium-sized employer, you are typically going to an insurance carrier through a broker or through an advisor. to purchase a traditional benefit plan and paying premiums and all the rest of it. And in that particular case, the insurance carrier is very much the center of your universe for obvious and good reasons. But where we're going to be focusing on commentary is on the self-insured benefit plan. So typically speaking, when you get into larger employers, whether they're single employers, whether they're multi-employer plans or trusts, most pharmacists aren't aware of this, but these plans are almost always self-insured, meaning they're partnering with an insurance carrier and or a PBM to be able to process claims on behalf of their plan members. But these self-insured plans, these large employers and these large multi-employer plans, they're the ones paying the bill. They're the ones underwriting the cost for this. The insurance carrier is an important partner in the facilitation of the administration of the plan, but they're not underwriting a lot of financial risk outside of maybe some catastrophic risk, which we'll talk about later. So the self-insured plans, and this was news to me when I started my pharmacy career, they're the ones paying the bill. And oftentimes they're sort of in the very, very background. We don't pay much attention to them. We think of this more as what's happening with, a large insurance company, or what's happening with, the group processing our claim, if it's TELUS or Express Scripts or whoever it happens to be. But behind all of this is the plan sponsor. And then lastly, we touched a little bit about their single employer plans, there are multi-employer plans, and there are benefit trusts. And where this is interesting is that you've got these entities that are created simply to effectively fund benefits. But what most people don't appreciate is that these private plans, these single employer, multi-employer plans, but especially these benefit trusts, they have a finite amount of money that's been allocated on a per claimant basis to fund all benefits, not just prescription drug. So you've got a bit of a problem here. In a lot of cases, you've got a defined contribution of money for a defined benefit of health benefits, which goes well beyond drug. And that's where we get into some real challenges and some real complexity. So from terminology standpoint, I think the big take-home message here is we're talking about the plan sponsor, and in particular, the self-insured plan sponsor. That's really the audience here that we're talking about in this pharmacy context. And the fact that these plans do not have an unlimited amount of money. And in some cases, they have a very fixed defined amount of money on a per employee basis. So here's the world of an ASO. An ASO stands for Administrative Services Only, meaning self-insured. Here's the world of a self-insured health benefit plan. And you can see the various different stakeholders here. Does anybody notice something profoundly bizarre about this slide? I'm not going to have you answer because it's a presentation, so it's a rhetorical question, which I know is annoying when people do this, but let's just reflect on this for a second. Is there something here that stands out as being really, really strange when you look at the ecosystem of a self-insured plan underwriting the cost of health benefits, of which drug is the most obvious and most prevalent cost? At least when I looked at this once upon a time and got my sense of my bearings as to how this industry is structured, it seems extremely strange that in the middle of the page in the gray box, you see plan sponsor, trust, multi-employer plan, but they're not connected to the pharmacy. They're not connected directly to the insurance carrier or the PBM. They're sort of off in their own little world, connected to their advisor and to their members, and that's it. And isn't that really, really odd that the group that's underwriting that much money is sort of orphaned off in their own little world? Again, if you're a smaller employer, you're using an insurance carrier to fund traditional benefits for you or in any form of health benefit, it would make sense that that insurance carrier or that third-party administrator, whoever it happens to be, is at the center of the ecosystem because they're the ones that are facilitating everything. But again, when you've got self-insured or ASO plans that are funding and designing their own benefits, isn't it really strange how they're not connected to anybody in the equation? And what has that sort of meant over time? The world was really different back even in the early days of Cubic, which predated specialty drugs and private plans by most measures. I think really in those early days of Cubic, the biggest issue we were seeing was the advent and the emergence of Remicade and infliximab in the marketplace. And even then it was still kind of almost Orwellian and Brave New World, and still very sparsely used in private plans, primarily infused in hospitals and things like that back in the day. And obviously, when the average prescription drug claim was $30 or $35, the world was a very, very different place for benefit plans, and for self-insured benefit plans in particular. There wasn't a whole lot there to worry about. In fact, do you know what freaked out most benefit plans in the early 2000s was Viagra and Xenical. That kept people up at night. Like somehow that was going to bankrupt plans. And, were we going to be using PPIs over Zantac? That was really the big concern, which now looking back at it is almost humorous that was even something people worried about. But that's where things were, call it 20 years ago. But then think about where the world has changed now, where you've got an enormous array of specialty products, orphan products, et cetera, where you've got a lot of these large self-insured plans cover 100% of the drug costs, with or without really low limits for out-of-pocket, meaning OOP for out-of-pocket, meaning that for most large self-insured plans, they may have, say, 80% coverage to a finite amount out of pocket. So once somebody hits $500 or $1,000 a year out of pocket, these plans will pick up 100% thereafter. Therefore, they're basically, they're covering the full cost, and nobody really sees what's going on because there's some magic entity that's looking after the cost here. The other thing that's emerged is that you've had these plans effectively, there's a single market for insuring against catastrophic stop loss. So if you're a large self-insured plan and you're worried about getting a $300,000 orphan claim, and you want to protect against that sort of financial risk of absorbing a chronic claim like that, you can buy catastrophic stop loss insurance from your insurance carrier. But typically speaking, there is only one market for that, and that is your insurance carrier. And the only way to sort of keep those premiums sort of modulating and managing those premiums the right way is to continue to increase that limit at which you can start to access it. So once upon a time, lots of people had stop loss at $10,000 per person. Once you got there, it was like, "Ooh, that's crazy." Hitting $10,000 per person, let's insure that. And then all of a sudden it goes up to $25,000 per person. Now, for a lot of self-insured plans, their stop loss is at $100,000 per person or more, or most of them may not even have stop loss if they're big enough, meaning they're literally on the hook for all of the costs right up to the end. But even if you're the first dollar on the hook for $50,000 or $100,000 of drug claims per person per year, it's a pretty big deal. It's a very different world than where it was once upon a time. It's also when you were paying a percentage of the fee as a claim fee when the drug was $35, that's one thing. But when you have to pay a percentage of your paid claim and the drug cost is $1,500 or $2,000 or more, it's also a big deal. It's also really challenging when you've got a lot happening with the spend, a lot happening with health, but you don't see a lot of what the issues are inside the plan. And I think that's what most pharmacists get frustrated about. They don't really see that most employers and most large trusts don't really have a good handle on what's driving health and where they need to be focused. So this is an actual case study to sort of facilitate sort of a broader conversation as we go through this. And by all means, you always ping me afterwards if we don't get around all the questions. I'm always happy to answer any question anybody has. These are actual numbers. So this is a plan sponsor that in 2021 paid almost $81.5 million for just drug benefits for their employees. The employees collectively out of pocket paid $1.5 million. So the vast majority of the cost is actually being picked up by the plan. There were nearly 1 million prescription drug claims transacted for this one group alone. So this one self-insured plan covers off 1 million drug transactions, or 950,000. But here's where it gets interesting. 42% of that spend on drugs was for specialty drugs, which probably makes up about 2% of the claims. So once upon a time when we were worried about Remicade, and Remicade was maybe, slowly creeping into plans, look at this group spending $81.5 million, of which $34 million is for specialty drug. And 87% of that amount are for chronic specialty therapies that are not going anywhere. And that's why the price of insuring against these has gone up so much, because these claims don't go anywhere. They continue year after year. So that's why the cost of stop loss insurance has grown. And that's why people keep having to increase those thresholds to 50,000 or 100,000, or just get rid of it altogether, because this is what's driving those costs. Let's get away from specialty for a second. This is pretty sobering. This particular plan, 8% of the total drug spend for the 2021 was just related to diabetes. So diabetes as a category, as a therapeutic area, was the most costly disease state in the entire experience, more costly than the disease states that are typically managed by specialty therapies like MS, Crohn's disease, cancer, you name it. Diabetes is number one. Diabetes spending in 1 year for a group this size went up by 17% in 1 year. The number of diabetics inside the plan went up by almost 12% year over year. And there are now 4,800 diabetics inside the plan claiming as of the end of 2021. And interestingly enough, if we take a look more deeply in the claims experience, almost 10% of those people are treating what we would call at Cubic severe uncontrolled type 2 diabetes. So almost 10% of these people are really having a bad way about managing their diabetes. So this is the world of an actual plan sponsor. 42% of their spending on specialty drugs. Most of that stuff is chronic. Now diabetes is really, really becoming a massive issue. We've got new technologies around monitoring blood glucose levels, which are great. We've got new diabetic guidelines from 2018 that have sort of revamped what happens when we get past metformin and monotherapy. Again, that's great. There's some amazing outcomes that we've seen and benefits of some of these newer therapies, but the cost to treat diabetes has really gone up. And look what this is doing to a plan this size. These are the kinds of challenges that these groups are dealing with that don't have an unlimited amount of money to address some of these health issues. And they have to figure out where they're going next. But here's another interesting stat. This exact plan had prescriptions filled for their members filled by 4,100 different pharmacies in 2021. So now we get into a different world. You've got a plan with 1 million scripts. You've got a plan with almost 5,000 diabetics. You got a plan where there's hundreds of people who have suboptimally managed diabetes that is very, very significant. You've got this world of specialty drug therapy, and now you've got 4,100 different pharmacies servicing their members. So there's an enormous distribution of what kind of care is happening, what kind of follow-up, what kind of plan, where are we going with all the investments that are being made in these employees' health? And this is the challenge that some of these plans are dealing with. So very quickly, to sort of maybe set some context to the rest of the conversation, what's already happened around pharmacies and plan sponsors? Well, the most obvious example, what's already happened is here are sort of 4 of the biggest specialty pharmacies that have become fairly ingrained in the plan sponsor world. Many of these would have partnerships with large insurance companies. And that's why we don't see a tremendous volume of specialty drugs going through standard community pharmacy, because they go through specialty pharmacies. And that's great. These specialty pharmacies are often very vertically integrated. And so they also have access to and manage patient support programs, and have direct links in with the pharma companies, which again is great. They're all part of a broader ecosystem of managing specialty claims. But this is, I guess we could say, this is pretty standard fare now in the marketplace, and this is what's already happened to date. And by all means, these aren't the 4 only specialty pharmacy vendors, but these would be 4 that I think most people might be familiar with. Then we think about, how is the space evolving today? So how's it going now? We've got, for example, Express Scripts has had an established pharmacy for quite some time. They're one of the largest, I believe they may actually now be the largest, or soon to be the largest pharmacy claims processor in Canada. I'm sure most people have heard of Pocket Pills, is sort of what they would call themselves, a digital pharmacy or mail order pharmacy with really interesting and useful app member interface and stuff like that. So they're very common. MedNow is another group, a digital pharmacy or virtual pharmacy, publicly traded company that would be in sort of, maybe you could say, a similar adjacent space to Pocket Pills, and they're doing a lot of marketing. TELUS Health is sort of following the lead of Express Scripts, and they're walking into the world of virtual pharmacy and have done some acquisitions in that space as well. So now you have the two biggest claims processors or PBMs in the country that are firmly sort of established in the pharmacy space. And that's already happened and is continuing to happen. And then most recently, most of you probably would have heard that Green Shield Canada purchased both a specialty pharmacy and I guess mail order or virtual pharmacy, maybe for lack of a better term. In the last couple of months, they've announced those acquisitions. And so this is an example of a carrier, an insurance carrier, getting directly into the pharmacy space as well. So interesting stuff. None of this is probably profoundly new to anybody. But that kind of shows us where the space is continuing to evolve with some of these stakeholders in the space. But then the idea or the question here that we're sort of throwing on the table and open for discussion is, well, where does the concept of a plan sponsor pharmacy differ from what we're already seeing in the marketplace? And this is really nice that we've got some commentary from the Discovery Pharmacy next, because they would kind of be in a very unique node as well. And I would sort of keep the Discovery Pharmacy as even separate from what we're talking about here, connected, but certainly a bit separate. So it's going to be really nice to hear a bit more about what's happening there. But how does the concept of plan sponsors getting involved in pharmacy, how does that differ from where we're at today? And sort of at a high level, because again, this is something that in 20 or 25 minutes, I could speak about this for 20 or 25 hours. So trying to distill it down, here is some thinking that I think maybe it may change some people's perspective about what this means and where it's coming from, but it also may stimulate some ideas about what's possible. And the reason why I presented the case study before was I'd like you to think about that case study of $81 million of drug spend for one single ASO plan against this concept of a plan sponsor pharmacy, to sort of connect the dots, say, what would this mean in a world like this? And what it means is, when you have a pharmacy, in a traditional pharmacy, and you're looking at profitability and you're looking at revenue and profitability, all of a sudden now cost avoidance becomes a lot more meaningful to a pharmacy where this connected directly to a plan sponsor, because that's actually worth more to a plan than just processing a claim more efficiently or more cost effectively and all the rest of it. So now you've got an idea around cost avoidance is that being interesting. So things like deprescribing, things like optimizing, why would a plan sponsor pay for therapy if people aren't going to be adherent to therapy? It's a complete waste of money. Why not ensure adherence to make sure you're getting some value out of the equation? So cost avoidance is a big deal. What does cost avoidance mean to an ASO plan sponsor? And what does that look like relative to making or fulfilling a claim through a preferred network more efficiently? What does that difference look like to them? But also, what's the concept of a cost offset to a self-insured benefit plan? And typically speaking, the cost offset is what are the impacts of improved health? What does that look like on the rest of the plan? What does it look like on the disability side? What does it look like across other extended health claims? That's really what's of interest to a large self-insured plan sponsor, is what are some of those offsets? What do they look like, and how do we measure them? The other thing too is we've got some very large pharmacies in this country that have solid market share in most plans, and therefore one would assume would have lots of data. But what data do we need to tell a story for a self-insured plan sponsor? And more importantly, what's the story that we're trying to tell? And I think pharmacy sometimes struggles with that, because pharmacy doesn't really understand who the actual payer is in most cases. And if you think it's an insurance company in every case, that's going to target and maybe color your perspective different than if you think, oh, wait, it's an actual trust or a multi-employer plan or a single employer. What actually matters to them? What do they need to measure? What do they need to see? How do they calculate return? What does that mean to them? And it's very different probably than what you would think about if you're just looking at this from a standard community pharmacy model. So then if we consider all of that, then what does the nature of opportunities for clinical partnerships look like between a plan-sponsored pharmacies and community networks across Ontario, across Canada? Like, what could this look like in a world where you have plan sponsors focused on the bigger picture, hopefully, and willing to make investments that actually move the needle from a health standpoint? If they're willing to do that, and now they're willing to look at drug expenditures and clinical investments as an investment, not an expense, then what does that mean in terms of potentially looking to partner in terms of the building clinical networks, partnering on programs, because again, if you're filling prescriptions for 1 million prescriptions a year, you need scale. You need to be able to have, if you've got 5,000 diabetics in a plan, how many CDEs do you need to be able to really meaningfully provide service? And then how do we take those service interventions and how do we do something with them? And how do we have some accountability behind what goes on with treatment plans and follow-ups and things like that? And so then we think about, here we are in 2022, and we're all so much more comfortable with technology and what technology can do. What does the role of technology integration play in facilitating some of this work? This doesn't sound so brave new world now in 2022 when all of us are sitting here on a Zoom meeting. What can we be leveraging to build these kind of networks? And then lastly, as opposed to this being looked upon as something negative or something like, oh, here we go again, pharmacy's under threat by another stakeholder group or another entity, or this is something negative. Does this actually need to be considered as a zero sum where there's winners and losers? Or is there actually an opportunity for everybody to win if the investments that are being made are actually producing meaningful health returns? And does that maybe all of a sudden open the door to different sustainable models of practice and sustainable models of investment that really, really change the landscape? And is that something that may in fact usher in a really interesting new world and a new ecosystem for pharmacy to participate in? And there may be very differing opinions, but I wanted to share that sort of to get the discussion going is, does this, if we look at this differently and we measure this differently, does this maybe change the landscape in terms of what this could mean for pharmacy more broadly? And maybe it doesn't have to be perceived as something profoundly negative. So with that, Annalise, maybe I'll wrap up my comments and turn it over. And again, later in the conversation, I'm happy to take any questions or field any comments that the audience might have.
Perfect. Thank you so much, Mike. Fascinating presentation, and just, I think, so much richness in terms of hearing about things that, at least from my perspective, we don't always hear about or talk about in pharmacy more broadly. So thank you so much for your remarks and for posing lots of questions at the end. I'm just going to turn it now to Jonathan to keep our conversation going before we turn to some Q&A. John, I'll just quickly introduce you. Jonathan Nan is the interim pharmacist lead at the Discovery Pharmacy. He's a graduate of the University of Toronto Leslie Dan's Faculty of Pharmacy right here, and John has spent over 10 years working in community practice. Making an impact in the lives of his patients fuels the drive to train, teach, and mentor pharmacists and pharmacy students to practice to the fullest extent of their abilities to provide better healthcare for all. John believes that positive changes in the pharmacy profession are shifting the profession towards innovative and novel models of practice. An open-minded integrator, John is passionate about bringing people together to reveal inner potential so that they can experience the interconnectedness of all things. John, I'll turn it over to you for some remarks, and for everyone online, feel free to type in questions to the chat box whenever, and we'll get to those after John's remarks. Thanks.
Awesome. Thank you, Annalise. So thanks for having me on the speaker series here. First off, a really interesting presentation, Mike. I think in that tight 20 minutes there, I learned so much, and it's just gotten my whole brain racing. So first off, I'll start just talking a little bit, give some context about where my background in Discovery Pharmacy specifically. So Discovery Pharmacy is an academic accredited community pharmacy with the twin missions of education and research. So really focusing on education, teaching students, as well as seeing how we can connect with our preceptor network and then the broader pharmacy community to enhance the profession, and then research looking at how to research new, innovative, as well as test all the different things that are being studied currently and see how that can impact practice. And all of that is built on top of a base of service. And I think what was really interesting in terms of this whole presentation was enlightening for me, as I'm sure for many who are listening, because getting that granularity between all the different players in the insurance game and who's paying for prescriptions really gives some context, and understanding the difference between, say, a plan benefit manager and a plan sponsor owning a pharmacy or running a pharmacy is really interesting, because as you said, like as you finalized in your last slides, looking at what is important to the payer, I think becomes really important. And from everything that you said, talking about cost avoidance being important and offsetting costs, this really does push, rather than, it really gives some kind of impetus to understanding the importance of deprescribing and looking at adherence, and having the data to understand where the adherence is at, I think is really interesting and really important. Looking at the data, I think data is something that in pharmacy, in regular pharmacy practice, we don't have a lot of understanding in terms of how certain interventions that we make with the patient individually kind of spreads out into their health and or maybe dishealth further on. And like you said, we're all sitting on a Zoom meeting now, talking with people from all over the country, I'm sure, and it's really time to look at how we can facilitate building that connection with other pharmacies, other healthcare providers, and really doing it for the benefit of the patient. And I really like that last point about considering whether it needs to be zero sum, whether there has to be winners and losers. I think when we begin to work together, there's some way that we can all win, because at the end of the day, when we're in healthcare, working within pharmacy to provide medications and counseling and looking at patients' therapy, at least from the pharmacy perspective, really are like, what is the data? What is the metric that we're looking at? Is it the number of prescriptions that we're dispensing, or is there some better way of measuring an individual's health? And really getting to that and understanding that is the challenge. So I think I'd be interested to know more about, in terms of Mike, your current company, looking at the data and looking at cost offset, because I think that's something, like you said, is sometimes difficult to measure, because how do you measure the impact of one intervention going further down the road if you intervene now and a patient doesn't end up requiring further medical attention, going to walk-in clinics or hospitals or whatever else is down the line. How do we really look at that, and how can we measure that and use that in a meaningful way within pharmacy practice? So I think that there's just so many things. I really do appreciate your time in talking about all the different things. I'm just going through my notes here, because there's really, it's like every sentence was like a little nugget of something that I am further learning for myself at this point. I think from my perspective, it really lines up in terms of the Discovery Pharmacy mission and my own kind of philosophy to how we look at patient care to really try to benefit the patient and have some type of meaningful change. And like you said, with the data in that example that you showed, where 8% of the claims that were processed were for patients with diabetes, and that it was increasing year over year. Those are really numbers, and diabetes is a disease state that there's been so much attention to, and there's certified diabetes educators and all sorts of supports. And I guess you wonder what further can be done, and even having that perspective of the one company being served, the employees of one company being served by over 4,000 pharmacies, the quality of care, the attention that can be given to the patient, the continuity of care, really are all big questions. And I think really getting that the right mindset and the focus of where we're looking and what we're looking at in terms of what does success or what does good health look like for a patient, is really kind of the approach that I've taken in my own practice. And I think that lines up well with the perspective from a plan sponsor, because if we can help the patient become more healthy, to me, more health doesn't necessarily mean more medications. And like you said, with deprescribing, it may in fact mean less medications and better management in a number of different ways. So really, I think this is, with all the technology and with the acceptance to technology going through the pandemic, and everybody having some sort of, or most people having some experience with this online virtual format, it really opens the door to considering what the partnerships and investments could be further downstream for pharmacy practice and for the benefit of our patients. So I think all of that is really interesting. I would love to hear a little bit more about kind of your perspective on that and where you're taking that kind of plan sponsor pharmacy idea, and if there's any work that's being done in terms of moving forward with any of those plans.
Thanks, John. Yeah, I'd love to open it back up to Mike, just for some remarks on kind of some of the things you've brought up. But thanks for that.
Sure, I'll keep some of my initial comments fairly brief because I'm quite interested in fielding any questions that the audience has. I would say the reason why this, just for kids. Okay, I guess we're recording. All right. In terms of the broader audience here, the reason why this topic came up is that the first, I guess you could say, fairly public plan sponsor pharmacy is launching this month, or scheduled to launch this month in Alberta, and it's the Alberta Retired Teachers Association, their pharmacy, and they're sort of, I guess you could say, first out of the gate in Alberta, because Alberta is obviously different from Ontario in the sense that anybody can own a pharmacy in Alberta versus, in most other jurisdictions in this country, it's got to be 51% owned by pharmacists. And so, we're starting to see that sort of seed of what they're doing be looked at and picked up on by other plans. And it's early days for sure. But that's not to say there's already some interesting stuff happening. Like we talked about, there's other partnerships that have happened. There's also innovations that have happened that have gotten out there. But this is the next wave. But I just want everyone to realize that this is actually happening as we speak. And I think it's going to become a bigger, I guess, part of things moving forward, but it won't be for everyone. Not every plan sponsor is going to have the scale. Not every plan sponsor is going to have the size and the wherewithal to want to be involved in being involved in a pharmacy. But it'll be, I think there'll be a select group of them that will think about this and take it very seriously. But I think the bigger part for pharmacy is the opportunity to say, like, well, then what do we do with this? And what kind of opportunity is there to be managing outcomes, to be measuring what's happening? Because the thing is, with these benefit plans, all of the data is there. There's so many things that can be measured outside of just the drug experience. I think the real opportunity is, how can pharmacy more broadly leverage what might happen in some of these plan sponsor cases? And then how can we apply that in other circumstances? Because some of those other partnerships that exist today, on the specialty side, on the non-specialty side, there's great. There's nothing wrong with them. There may be learnings from something like this that can be built upon by other models and other partnerships. I think the exciting part for pharmacy is that we can finally tie what's meaningful to a plan sponsor back to the outcomes that pharmacists are sort of central in terms of being able to help to oversee and help to manage moving forward. But I just want to reiterate to the group that this is the cat is the horse is already out of the barn, so to speak. Maybe at least I'll turn it back. I think there was a question. I thought I saw a hand pop up, so maybe I'll just wait to see if anybody has anything they want me to clarify before I ramble on any further.
No problem. Yeah, I know, Ernie, I saw your hand up. I think we have a small group today, so happy if you want to unmute and ask your question directly to Mike or John, or more broadly. And if you could just introduce yourself as well for others.
Thanks, Annalise. I'm Ernie Avila. I'm the executive director for the Discovery Pharmacy. I'm really curious with regards to the model of the plan sponsor pharmacy. And you mentioned it's the Retired Teachers Retired Teachers Organization, RTO. Is that what that stands for?
It's the Alberta Retired Teachers that are first of the gate. Yeah,
So I'm assuming they're a non-for-profit model as well.
that's right. That's exactly right.
I think one of your slides looked at the tension between sort of being a profit center versus a cost center with the cost avoidance sort of strategy for plan sponsors. I'm just wondering with regards to traditionally community pharmacy or like pharmacy right now is based on generating profits. And so that's how it's incentivized. I'm just wondering, how does your model or how does this plan sponsor pharmacy model, is it incentivized on patient outcomes or, if it's not being incentivized traditionally with profit?
It's a great question. Yeah, I mean, in this particular case with the retired teachers, it's a bit of a different animal, because with the retired teachers, obviously you've got different offsets and different considerations you're looking at than an active group. So when you're thinking about an active employer group, the bigger issue for them is thinking about how do they keep people engaged at work, not on short or long-term disability. How do they enhance productivity and all that kind of good stuff? And how are they managing the broader benefits portfolio is more top of mind for an active plan. For a retiree plan, it's more around ensuring consistency in clinical service, and it's looking at helping to manage these chronic diseases and looking to really get hands-on and it's almost having clinical experts on salary to be able to sit there and be focused uniquely on the needs of their individual members. So there's a slightly different piece there. I think moving forward, the retiree model will likely be probably a bit of an anomaly. I think where there probably is going to be bigger uptake moving forward is going to be in the active plan sponsor world, because of the extent of the things that they touch and their plans touch. So let me I'm just looking at my screen here. This is not the same example I had in my slide deck, but Ernie, you asked a really good question. So I like numbers. So let me throw some numbers at you. So I'm looking at a group whose drug spend in a given year is probably around 75 million, give or take. Again, a different group from the one I showed before. Their long-term disability costs, direct long-term disability costs, because they have a self-insured disability plan, it was $101 million last year. So more than their drug spend by a fairly substantial margin. If you add in their short-term disability cost, direct disability cost, it was 43 million. You add in those two numbers, we're talking about $145 million worth of direct cost compared to half of that on drug claims. So, as pharmacists, we get really focused on the prescription drug benefit because it's our world, it's what we know. But we sometimes lose sight of the fact that when you're talking about a plan sponsor, they have a whole array of benefit costs on the health side, and of which disability isn't really even considered a core health benefit. It's considered something, it's disability, it's distinct. It's not part of the extended health and drug and dental piece. If we can start making impacts on the frequency of disability claims, the average duration of claim, things of that nature, imagine the kind of financial impact that could have for plans like this. And then imagine the kind of financial resources that could be opened up for investment in other areas. And I think that's where the real excitement is. I think a lot of people look at things and say, oh man, there's no more money in healthcare. There's no more money in these benefit plans. What are we going to do? There's a huge amount of money in these benefit plans. It's just not always being allocated in the right spot. And when it is, nobody's measuring the outcome. So if there's something really wonderful happening, we don't know about it, because people aren't doing that measurement. And that's the fundamental piece, I think, that's got to underpin everything moving forward.
No, that's really interesting. So you're looking at all of the controllable costs, whether it's the direct controllable costs, like you're saying here with the long-term disability and the short-term disability. Are you thinking the drug spend is more of a controllable variable cost? And you're sort of balancing that out in that model?
That's a really interesting question, and I'm glad you brought that up. There are some costs that I think are not controllable, right? So when we're dealing with costs of specialty drugs for conditions that are, let's say, autoimmune conditions and things like that, we can't impact that in a meaningful way. And I think we have to be honest with ourselves. That's not, really what we can do there is we can ensure that somebody has the most appropriate evidence-based therapy for their condition, but we can't change the course of MS, but we can help ensure the most appropriate therapy and supportive therapy when we get there. What we can do, though, as pharmacists and frontline healthcare professionals across the board is, what about pre-diabetes, diabetes, cardiovascular conditions? What about mental health conditions? And now, again, and I'm not just talking about it from a pharmacotherapeutic standpoint, because we could get into a big debate about the appropriateness of pharmacotherapy in some elements of mental health, but we're talking about how do we start to leverage and how do we free up resources to allow plans to invest in solutions that can address some of these things as well. And they may not all be pharmacy services. Some of the solutions in mental health may in fact be something very different than a pharmacological intervention, but in some cases they will be. But there's a whole world around prediabetes, cardiovascular conditions, and things of modifiable risk factors that we can be more aggressively involved in. And there are just other things that the focus from a pharmacy and a clinical standpoint has to be around appropriateness and optimization of therapy. But I think that's a very good point. And what concerns me about the focus on specialty drug is that specialty drug, we're typically dealing with situations where we cannot have an enormous impact on the clinical outcome. And it's getting worse from the point of view of the newest therapies in the market and the drugs for orphan drugs for rare diseases. I mean, it's wonderful to see the kind of innovation that's happening here, but we can't impact some of these genetic diseases in a meaningful way today. And a lot of these rare diseases are focused on things where we're doing our best to manage clinically what patients can or can't do moving forward. But I think we have to look more broadly. And the other thing is, you can't just look at the drug benefit expenditure, as that's not where the key performance metrics will come from. The key performance metrics about managing diabetes are going to come from way beyond the world of just the drug benefit. But if we're only looking at that, we're going to miss the bigger picture. So you've raised a really interesting point, Ernie. I thank you for doing that. But this is where the focus will be different depending on the group and what they're looking to achieve.
Fantastic. Thanks, Ernie. Do you have a follow-up?
No, I just said thanks very much, Mike.
Yeah, no, thank you for the question.
Great. Yeah, I'm sure there will be opportunities for more conversations between DRX and yourself, Mike. 2 more hands up. Leslie, I will pass it over to you. Just please introduce yourself as well, and then you can ask your question.
Hi there. Really super exciting talk today. I'm so excited by this. Just a bit of background, I worked in the UK and I used to help manage drug budgets for GPs, and that would involve going into their practices and helping them. For example, we had a quality and outcomes framework where GPs were paid by, for example, the number of patients in their surgery on a coronary heart disease register, the percentage of those that had their blood pressure controlled to the guidelines, the current guidelines, cholesterol controlled below the guidelines as well. So we would help our GPs kind of use prescribing and actually do patient consultations to meet those goals, to help them, because they would be financially rewarded for meeting those goals. So I'm just wondering, and also there was a big movement there to, I wasn't working at a community pharmacy, I was paid for by the government. But they were trying to kind of, with technician-led dispensing, move pharmacists out, so for example, an afternoon a week, or going into GP surgery and helping them kind of manage their prescribing by, reviewing their patients. And the big focus at the time was diabetes and coronary heart disease. Like you said, the the big spends like on the anti-TNFs and stuff like that, we wouldn't really do much kind of patient level stuff. It was more just managing the kind of costs and appropriate use according to the criteria at that time. So I guess my question is, in terms of data, we were lucky we could get the quality and outcomes framework. We could access all of our GPs' data for meeting those targets. So wondering where you would get the data from. Like, is there any movement? Do actually these plans, I can't remember what you referred to as, do they get access to kind of patient level data to be able to check, oh, this patient's diabetes is controlled, this is great, or they're not? Is that level of data available?
Leslie, thanks very much for the question. And it's a complicated, it's an excellent question. It's a complicated answer. I'll try to streamline as much as I can. If we're focusing on large self-insured plans, again, the kind of plans that are looking at the bigger picture like this, they do have access to all of their transactional claims data. So they're able to understand across every benefit line and disability what's happening at a claimant level. Now, typically speaking, that data is encrypted and uniquely encrypted with a similar encryption key across every benefit line, so that you're protecting the privacy of members when you're looking at the bigger picture. But the exciting part for a pharmacy and a plan sponsor pharmacy is the idea that you can now start to integrate in other pieces of information you didn't have access to before. So for example, information that would come off the pharmacy management system, any of the documentation and notes and inputs from care plans and follow-ups and measurements, things that aren't accessible because they're not plugged into EMRs today. This is where plans are trying to be as practical as they can be. Down the road, 5-10 years from now, oh boy, the sky's the limit about the things you could implement and bring together. I have a lot of admiration for what groups like TELUS are trying to do in terms of building this digital ecosystem in healthcare, and I understand what they're trying to do, and it's a massive undertaking. And so I think as we move forward, it's going to be a different world for sure, and there'll be more opportunity. But just think about some of those additional pieces of insight that can come out of what goes on. But then also, Leslie, think about the ability for a plan sponsor pharmacy to be able to compare and contrast the outcomes of their members against those that are not receiving the same kind of clinical support, and not just from their own pharmacy, but from an extended clinical network. There's so much that can be done. And I think the technology is only going to make it that much easier. And I also believe as time goes on, we're going to be less concerned about, oh, gee, what happens, the genie out of the bottle with privacy. I think everyone will be comfortable enough that we can maintain privacy while trying to look at the bigger picture. So the good news is the amount of data that these plans have access to is enormous, and it's a really, really good start. And I think it can help take us to the next level for sure.
Thanks. And do you think the government will do the same? Like, do you think the government, I mean, will they, because if we're going to move, do you think we'll move to pharmacare and then I guess move towards, like, how do you think that will fit in? Sorry, I think I'm taking someone else's time, but maybe another time.
That's a great question. That's a great question, Leslie. So
we could have an entire session about that, Leslie. I would say that one of my hopes would be that when you have a robust, sophisticated business case, financial measures, health measures that could come out of something like this, I would really hope it would help to inform government policy decision-making moving forward. That would be my intent, is these are plans trying to solve problems today. And how could other stakeholders like governments, and then also it's great to hear from John, like how can other stakeholders like Discovery Pharmacy, what other roles can they play beyond the scope of what these pharmacies are doing too? So I'm hoping this becomes highly, highly collaborative moving forward and everybody can learn from it.
Thanks. Amazing. Thank you.
Thanks, Leslie.
Thanks, Leslie. Both great questions. Chris, I'll pass it over to you now.
Thanks very much. Mike's good to see you again. It's been a long, long time.
You too, Chris.
It's kind of interesting to see you front and center at U of T. My background is in private insurance, and I've done a lot of work more recently in drug policy, including pharmacare, rare disease access, drug access, and so on. I remember years ago working in early days when pharmacy was trying to establish the quality of services. This is a point you brought up, I think, earlier, and it was really challenging. because you've got data scattered over many different places in the insurer, in the government, in the public health system, in pharmacy owns their own systems. My question is data related, but rather than more clinical or solely clinical, it's about the quality of service. Pharmacists are all regulated. Pharmacy techs are in some provinces, but that doesn't mean they all provide the same services to the same standards. There are no standards. How would, in a partnership idea with private payers or with governments and with the profession of pharmacy, and in fact, probably the industry of pharmacy, how would quality of service be established, negotiated, and then monitored and then improved to try to improve the opportunity for better patient outcomes?
Oh boy, Chris, fantastic question. I would say this. I would say that when you have, in the case of the case study I showed, when you've got 4,160 pharmacies filling prescriptions, we're really just paying lip service when we're talking about trying to establish any kind of quality metrics, because here these plans are, everything is happening at that scale, and it's really, really tough. I think the intent in a model like this is to say, here is where we want to focus. Here are the key areas, and this goes back to some of the comments Leslie was making. What does a broader network think is feasible? What kind of metrics, what kind of measures are feasible? What can we actually collect in an efficient way and share in a way that's thoughtful and meaningful? What does that look like? What kind of credentials do we need? What kind of expertise do we need? I think that is going to become probably a very central and a very, very complicated discussion. My hope, Chris, is that it doesn't get bogged down into people seeing the glass is half empty. So when you see, pharmacy stakeholders saying, well, the glass half out, well, what about this? And what about this sort of worst case scenario? What about this worst case scenario? I really hope that if a plan says, listen, we're doing this, would you like to join us or not join us? Would you like to participate or not participate? Do you think you can add value here? And do you have other things that you'd be adding value? Would you like to join? And how would you like to join? I would hope would be very welcome. Be like, oh, great, thanks for asking. Here's how I think I participate, as opposed to trying to corral, hundreds and hundreds or more stakeholders and try to say, hey, what can we do, when there's not really any accountability, or there's not this way. It's sort of like, well, the train is going to depart. Who wants to jump on it? And we don't have to solve everything on day one, but we have to have a commitment to everybody kind of pulling in the right direction, because the outcomes and where we can take this could be something really, really special. And if everybody wants to see the glass as half empty, and if everybody kind of wants to shuffle at a little tiny pace, then you know what, this isn't the train for you. And we'll get back. So, because Chris, I think if we don't take advantage of this opportunity more broadly to measure things, we're going to lose a big opportunity. And I think it goes back to the last question that was asked around, being able to try to come up with some insights and measures that will inform more broad public policy and health policy. And that's your domain, Chris. Like, I just think it would be really great to get there, but I think this could be the impetus to say, well, I'd rather be on the bus than off the bus, and how can I contribute? And I'm hoping that's going to be the motivation to really keep this positive. Chris, I think about the way big tech solves problems. Why is it they always see things as possible? Always. They solve massive problems. How many meetings at Tesla or SpaceX are about seeing the glass half empty, right? How many meetings at Apple and Google are about seeing the glass half empty? None. I'd really like to sort of borrow some of that. I don't know. We don't have to have all the answers. It doesn't have to be perfect. And what's the best thing that big tech does? They beta test, right? They don't try to get perfection out of the gate. They'll launch and then they'll iterate and go from there. I'd really like in healthcare more broadly, and certainly in pharmacy, speaking as a pharmacist, I'd really like us to take some of that sort of that mentality of, well, we don't exactly know where the end destination is going to be, but we all agree that this is a good path to be on. And it's nice to have, it's nice to be actually on a vehicle heading in a different direction, as opposed to kind of spinning in an axis and doing the same thing. So Chris, such a thoughtful question. I can't do that justice in this amount of time. And I think more importantly, you've highlighted to me, thinking about your question, how this has to be at the very top of the list on a next step. So thank you for that. And good to see you as well. You've aged a lot better than I have.
Thank you both for that. And
flattering.
hopefully there will be opportunities for you to connect as well. I'd like to, if people are able to stay on, Mike, if you have a few extra minutes,
Sure.
Jim, if you would like to ask your question, I think this session has been fantastic just in keeping so many people on the call for so long. So Jim, if you're still on,
problem.
I'll quickly
I'm
pass
still
it over to you. Yeah.
Yeah. So Mike, thanks for the really interesting perspective of the insurance world. Frequently when you're practicing and you're giving out prescriptions and people say, why am I not having covered? You don't know all these different layers. And it's very hard from a practice perspective to trying to explain to people why they've got co-pays and this and that. So it's interesting to know all these different pieces. My background's generally doing clinical trials and health technology assessments, linking data and doing things. So another part of my research job. I'm just curious whether or not you've come across any discussions from an outcome measurement standpoint where there's been discussions to actually share data with places where we have public data. Because part of the challenge is that the insurance data is siloed. And as you mentioned, long-term disability, short-term disability, but without hospitalization, ED visits, physician visits, we are actually not able to actually get the full picture from an outcome standpoint. So in your discussions, has there been any mention of sharing this data with a central public repository? Because we have two very discrete domains of our data in Canada, the public and the private, and without the two of them coming together, we have incomplete outcome measurement for anything that we're trying to do, I think, within this domain.
It's a great question again. This has really been enjoyable. I wish we had more time to have these conversations. The quick answer to your question, Jim, I think would be that I'm extremely bullish that will happen because some of the largest benefit plans that are considered private payers are actually public sector employers. So interestingly enough, public sector employers are private plans. And that seems a little strange when we think about it, right? That, but they are. And so at the end of the day, to the extent that you start to see groups in the public sector looking at this as an opportunity to sort of change the model and make the most of their funding, then I think there's a huge, huge incentive for them to want to share that more broadly because they are publicly funded. They want to bring some of this back. And I think that's where you're going to see a real sense of collaboration, because the purpose here is not going to be a for-profit model to start off with. It's going to be something different. I'm very bullish on that because most pharmacists aren't aware that the biggest payers are publicly funded private plans. So why wouldn't governments want to say, hold on a second, we're shuttling a lot of money into benefit plans for, municipalities, hospitals, universities, education, healthcare. Interesting. Like, hey, what can you guys share back with us to help us make better decisions? So this is where we could start to see a really, really positive cycle of engagement and collaboration, and hopefully new data that people haven't seen before. And so, yeah, I'm very, very excited at that opportunity. And I think I can look you in the eye, Jim, on this call and tell you that I think that's a real possibility just by virtue of the fact of who these big plans are and what they need to be thinking about more broadly.
Perfect. Thanks a lot. Very good.
Thanks for the question.
Thanks, Jim. Thank you, Mike. I'm going to pass it over to Zubin quickly to close this out for the day, but just on behalf of myself, very quickly, thank you so much for such an interesting conversation. I agree. We probably needed an hour and a half for this easily. So thank you.
Well, thanks for the invitation, Annalise. I really appreciate it.
And thank you, Mike, for a very interesting, thought-provoking presentation. Annalise and I were chatting in the background and saying, some of you on call me remember a few months ago in our speaker series, we had Joseph Berger from McKesson on presenting sort of McKesson's proposals for a national pharmacare program. We think it would be fascinating to invite Joseph and Mike to discuss the potential for national pharmacare and sort of what could be learned in order to prepare Canadians and the healthcare system for that day in the future. So you're not done with us yet, Mike, just to warn you. But for
That's
now,
okay.
we are done.
Thank you.
Thank you all so much for attending our final CPE speaker series for this academic year. We look forward to welcoming everybody back again in September for a brand new series of exciting speakers. Thank you especially to Annalise for all of her work in organizing, moderating, and hosting our events. Thank you all so much for joining. Have an enjoyable summer, and we'll see you soon. Bye-bye.